US Thanksgiving, this is lending to quite the bottleneck in terms of having internet connectivity broadband. There may be an impact with respect to the information via these town halls. Try to get it on the air today. If not, we will come back to the questions, but the questions can be sent to fnhma at ihtoday.ca. Over to John.
This global pandemic. I'm still thinking about those incredibly low over 1,400 active cases on reserve across the country as of last week. again, still linked to small gatherings, to large gatherings. That would be great. We did so well for so long. There is secondary trend. Which had October for the last 6 weeks. No cases on reserve for several months until their first case at the beginning of September. Increases there. Cases last week, just over 70 cases this week, but no new cases today. I'm happy to report. So those public health measures, including quite a lockdown, are moving things in the right direction. Though we are expecting a little more community transmission. It hasn't been that long. I think it's a bit early to declare it over. The Atlantic region has had no new cases, and the total number of affected communities has increased from 201 communities total last week to 218 this week. Of communities with active cases is now at 128 communities, and that's up from 101 last week. So we have historically, actually, though, done better than other Canadians, but those better outcomes have been diminishing in the last while, but our hospitalization rate is still only half of that of the general population in the country. Our case fatality rate increased from about 1 in 5, or sorry, 1/5 of the Canadian populations to now about a quarter of the fatality rate of other Canadians. And our attack rate per 100,000 has increased from what used to be 1/5 of the Canadian rate to now about 2/3 the rate of the general Canadian population. And that's a comparison between the end of June and now the end of November. I think it's important to note that we're still seeing very mild disease in children. That's and younger. In fact, the hospitalization rate for the 18 and under crowd is virtually zero. And I think that's very important as we start to talk about who's going to be vaccinated first in our communities. And I hope that community leadership are preparing for that kind of decision making. We are certain there won't be enough vaccine for all members in most Indigenous communities. So most Indigenous leaders will have to decide who are the priority groups. And there are some good hints. As I mentioned, children have very mild disease. And I think we all are seeing in the news that older groups are more profoundly affected or more severely affected. And that those in long-term care homes can have risk as well, and many other groups. So leaders will have to decide who will be first in line when the vaccines start to appear, and who will wait for the second, third, fourth, fifth waves of vaccine. So I'm just going to stop there. I'm really happy to take questions at the end of this time. And again, I'm really happy to speak to you, and I wish safety to all of you today.
Thank you so much, Dr. Adams, for once again letting us know what the landscape is across Canada. You hinted at this last week as well, and that was to, encourage leadership to now start looking at who are going to be the priority populations that should be considered first for vaccination. And a big hint that typically our youth are more resilient in terms of this COVID right now. So I will come back to you with questions, Dr. Adams. And one of them will be, how are you going to spend Christmas, right? We're looking at how to keep our bubbles small. So I'll let you think about that. Now I'd like to go over to Kim Daly. Kim, you are going to let your inner geek shine right now. You're going to tell us all about immunization and vaccination and how we can keep these tools to protect our nation. So welcome, Kim, to the First Nations Health Managers Association Town Hall.
Thanks so much, Marian. I think I regret sending in my bio to you that identified myself as a nerd. But I have to give that little preamble, because when I get into this, if this is too nerdy for you guys, totally my fault and Marian's fault for inviting me, because these vaccines are very exciting for me. So I wanted to give a little overview. Myself and Evan and a few others at ISC have been privileged to be at tables where we're discussing the vaccines, and we've been talking about them since September now. And as we talk about the vaccines, all this information is coming in, and we hear about people who are nervous about the vaccines, and then we hear about people who are excited like me about the vaccines. So we really want to make sure everybody has the same information to make the best decision for them. And much like Evan says too, is that realistically, we know what the art of the possible is with the amount of vaccine that's coming in. So the first part I want to really review is vaccine safety in Canada. And if you're brave enough to watch the news and watch the American news, which is partially entertaining and partially scary, then you will see that they have been bragging about getting the vaccine in sooner. And there's a lot of criticism about the time it takes. These negotiations about the vaccine were happening way in February. We did put bids in like other countries, but if a country is manufacturing the vaccine, they of course have the obligation to provide for their country first. And one of the other parts is in a vaccine safety. Health Canada has one of the most stringent safety protocols, and we're really proud of that. So we can go forward with confidence about receiving these vaccines. So there's 6 stages of the vaccine overview, and most Canadians kind of lose interest around stage 4, but stage 1 is development. So the vaccine is being developed. We put in, bids for 5 to 7 vaccine companies because we knew that the chances of all of them being successful were not great. And lo and behold, so far, a lot of them have been doing really well, but they're still in clinical trials. So I need to keep saying that none of these have reached the finish line. We know that Pfizer and Moderna have been in the news, but I need to remind you, they have not reached the finish line. They are not ready for distribution. They haven't gone through any of the trials. They've been submitted in the States, but they still haven't gone through that. So testing and approvals, and the numbers are different. So most vaccines that you'll receive that you're receiving now have gone through decades at least, some of them longer, of testing and approvals. We have a continual process where we monitor vaccines and start to see what's going on with them. So they, for these vaccines, there's about 30, the first phase was about 100, and then we moved and bumped up to about 50 to 500, and now we've gone up to about 40,000. So that's reassuring when we get to those numbers. So phase 3 is when we hit the 40,000 review, and that's been very reassuring that, so far they've made it through that. So once it gets to recommendations, which is, where phase 3 is, or step 3 is, in recommendations, that's when we start putting them into the regulatory bodies and making sure that they'll fit. So why do we only have the 6 million doses in January, which is really going to equivalent to 3 million because you have to get 2? Because the companies are businesses as well. So they could not go and mass produce only to not pass through and then have to get rid of them. So there's an element of manufacturing, storage, and transportation that needed to be put in there. So now that they're getting to that finish line, we're hearing that they're ramping this up. So that's important to know. It's not a lack of preparation, but they also have to be protective on their part too. Step 5 is the part that we really hope is the simplest, but because these 2 in track 1 have a lot of complications, I don't want to say complicated, a lot of logistic differences, that step 5 is vaccination. And getting those needles into arms is really where my job starts and finishes. So how to get the vaccine into the communities, how to get the people to vaccinate. So, in previous, you would talk about nurses vaccinating, but now we're calling them vaccinators, because we know in urban centers, we have pharmacies who vaccinate. We have in the military, they have medics who vaccinate. So we really want to leverage anybody who can vaccinate using this vaccine. So step 5, I would say, is our hardest point at this point, but step 6 is a really important part that we haven't played a major role in the past, and I really want to encourage you to play a role in, and that's monitoring. So, as we watch, the States will get this first. There's a couple of other countries that'll get it. Their due diligence is to monitor this vaccine. So what was the effects of it? And then ongoing monitoring. So we don't know yet if this is a lifetime vaccine or if this is going to last a year and we'll need to do this all again next year. So we don't know. This is not going to lift restrictions immediately. So when those monitoring questions come up, that's the important part, is to know what goes on from there. So COVID-19 vaccine is no different. This is how we run all our vaccines, and COVID-19 vaccines will do that as well. So I'm going to talk about tracks. Track 1 is January to March. And this is the one everybody's ramped up about, but don't forget it's a year-long process. So I myself do not fit into track 1. I will not be a candidate for track 1. And I'm okay with that. I've learned to live within this, and I know that there's a light at the end of that tunnel. Sometime in spring, early summer, I'll be able to get this vaccine. I really want this vaccine for those who are most at risk. And I think as Canadians, we need to join together in that commitment. So track 1 is Moderna and Pfizer. You've heard about these two. We're really lucky. They're both about 95%. So there's no one that's better than the other in that manner. They both take 2 IM. So IM is up here, upper arm. And one is 21 days apart and one is 28 days apart. That's really important. So it's not just a 1 dose, you're done. So we really need a commitment from our clients that you're going to come back. Otherwise, it wasn't worth having the vaccine. So one of our jobs here is when we get these vaccines that are difficult to get across the country into the community, we want enough to do both vaccines. And we want the human health resources to be there to do both vaccines in whatever way it is. But the exciting part about this, the nerd part of this, is mRNA. So if any of you are as old as me and remember H1N1 vaccine, I was working at FAC and was really excited about the rollout of that vaccine. But I also had another job where I worked with pregnant women. And so the H1N1 vaccine had some really complications with it, with the adjuvant in it, right? But all of our vaccines that come out usually have an adjuvant in it. And, you know, those vaccines have adjuvants so that they can be transported easier, that they can be preserved longer. There's a lot of rationale, but it came to a fruition, and there was a lot of controversy about it at the time. And it really started to limit some of our vaccine readiness. We were really excited, though, in the Indigenous populations, they did step up for this vaccine. You know, they informed themselves and knew that the adjuvant was no different. So you heard things like there was formaldehyde in it. But what wasn't going along with that is there's that in your bread as well. So, you know, there are things that we're eating every day that have that. So it was a little bit of misinformation. So my whole thing on our talks is to make sure I give you all the information. So here's what we know about mRNA. It's brand new. Does that scare people? Sometimes, yes. If you're a type of person who has allergic reactions to things, maybe the brand new vaccine brings you a little bit of fear. That's legitimate. We do know that there are no adjuvants, there's no preservatives. So that's why it's more fragile to travel in, but that's kind of exciting to know that. In traditional is what we're calling the other vaccines, traditional vaccines, it is giving you a little bit of the weakened disease. And that's what always gives people that little bit of, oh, I got the flu shot and then I got the flu. That doesn't happen, but it's probably more that you gathered together with people and somebody was sick. But people are always worried about this. That's not what mRNA does at all. It trains your body. So if everybody's seen that picture, which is, I hope somebody gives me an art piece with coronavirus on it with the big spikes out of it. That's my favorite picture this year. There's one with a healthcare worker in front of it. I love that one. So it trains your body to build that spike itself. Like, how remarkable are our bodies to do that? So it has, you don't inject something new into it. It just trains your body how to do that. So wow, to me, exciting. So that vaccine is not only evolved. Yeah, I know. See, there's a nerd in Marion too. That vaccine is not only available from January to March. So that's some of the clarity that you guys need to know. That's available in larger quantities going through the year. So the real smaller amount is the beginning. We can hunker down and wait for it to come out in the next one, right? Like if we're not in that risk group, we can hunker down. So the Pfizer vaccine, and once we see it go through, there's some complexities with it. It's the -80. So and it needs a special plug. I'm not an engineer nerd at all, so I always say a special outlet and plug. So some of our communities will not have that. We can get some traveling ones to get there. It also comes in 975 doses. And we want to be good stewards of this vaccine. So if it's a community of 200 and we have a tray of 975, even with 2 doses, we're wasting half. So we would hope that that would not be a candidate. We would move to a Moderna. But in the first track, Moderna has less available. We figure Moderna is going to be about 2 weeks behind Pfizer at this point. Could change. So that's a little bit about the vaccines themselves for track 1. We have been released some information on the more traditional vaccines that are coming out for track 2. But remember, these mRNA will be there also and in more plentiful. Today, it did come out in the next vaccine that's more traditional that they've had a little blip in their radar. So they're going back. So it might take a little bit longer, but their efficacy rates are coming out to be pretty equivalent, which was a big thing that was discussed yesterday at the AFN task force, is that, you know, if one of them's 75% and this one's 95, well, I want the 95%. Well, you and me both. And I think that's the best chart to go down. But again, if you're nervous about a new vaccine, then maybe you go to a more traditional vaccine. So you might have heard what the key populations are. Dr. Wong and Dr. Evan Adams are at all of these tables where the National Advisory Committee does go over these, and they are championing the cause. So there's some discussion if it's remote and isolated or Indigenous, remote and isolated. you know, what we're really trying to state is if it's an at-risk population, wherever they're living, they need to be part of the discussion. So we really want Indigenous leadership to be at the tables where these allocation conversations are happening. And that is not ISK. That is not me being at the table. That is inviting Indigenous leadership to speak for themselves, to speak for their population. So we're really encouraging that. I've been attending a lot of bilats, and understandably, I hear it from the provinces and territories. They're overwhelmed by the magnitude of this, but that is not a reason not to engage and to have those conversations. So we continue to push that mandate that everybody needs to be at that table to make those decisions. ISK role here too is help bridge some of the gaps. So if they say, well, we'd love to get that into this community, they have the risk, they have the ability, but we don't have this, we want to provide this. So we have put into FAC that we want some of the freezers to be allocated to ISK, so we can put them into communities that have the ability to maintain these freezers and use these vaccines. The supplies, you may have heard, much like PPE, there's a shortage in supplies. Because this is a 2-dose vaccine, there's even a bigger shortage. So some of the needles and syringes, cotton swabs, just some of the oddities that you need to give a vaccine campaign. Well, we put in, and FAC is giving, I think we're getting delivery today or this week of those supplies. And the biggest thing we want to do is get those out to the communities that need them so that that doesn't hold us back. Human health resources, we're trying to find out what our needs. We already know that there's shortages in staffing already to just deliver care. We don't want this to take away and subsidize away from the care that we're trying to provide in communities. So we are putting out there that we will need assistance with delivery as well. So we're hoping that if you haven't heard from province and territories in planning, that you do get invited into those tables. The delivery of the vaccine is somewhat at the hands of the province. So they are allocated from FAC, but again, we've been at the bilats to say, you need to let us know. In order to plan, we need to know how much vaccine is going to be set aside for us to utilize in our communities. No one vaccine over the other unless a community decides on their own, in their own leadership, which one is. We have created a guidance document because administering this vaccine is going to be different than doing the flu, measles, mumps, rubella. You know, we used to call it mass immunization, but we really don't want to gather people together and put them at risk to get this vaccine, especially that high risk group, but any of them we don't. And then we talked to FAC about a responsibility for a mini clinic. And so a mini clinic is, you've got your gymnasium, you've got your friendship center, and you want to turn it into now a clinic to administer vaccines. Well, they have 25 of these now for us across the country, really earmarked for our Indigenous communities. So these are going to be a little kit. You bring it in, it's going to be a giant kit actually, but you bring it in, it gets set up. We're hoping the human health resources that come in set this up a day or two before, then they come in with the vaccine and it's set up and then torn down and taken back. So, you know, to think about reusing so that we don't set up at the side of a desk of a human health resource, of a health resource that's already struggling, you know, a health center or something else, and gives capacity back to some of the urban Indigenous areas, such as the friendship centers that might be able to do this. And so, yeah, and our guidance document, as I said, has been developed to assist with that. If this, then that. If they come in with the cold, do they wear a mask? Do we provide the mask? All of those are in here as much as possible to be planned. Our planning has evolved with each time. So when it was, Moderna was a -20 vaccine and Pfizer a -80, and now Moderna is -20 to get us there, and then 30 days in the refrigerator. So that has changed everything for us. Pfizer had said that they were only going to deliver to points of vaccination. And when you first hear that, that doesn't make sense. Then I was on a call with Pfizer and they laid it out. If they were delivering it to Toronto City Hall, then it needs to be delivered there. It cannot be walked across. One tray cannot be walked across to the long-term care facility that's across the road from City Hall. Nope. Everything has to be done there. So that really limited us. And in the contract, there was only 75 points of delivery. That was limiting. That has changed since then because we came to the table and really said, this is really doesn't put us at a place of equity at all, unless you're planning to have us as part of the delivery too. So we would need to be delivered into certain areas. So that has changed. Pfizer has come back that they will do more points of delivery and that it can be moved as long as it's still in the frozen state. So we put in orders for the freezers. They're called little bar fridges that can plug into the planes where we can move these trays. So we're really excited about that. We're working more with friendship centers so that they can be utilized as a source. You know, I don't believe if people are informed of the vaccine that it's always that they're choosing not to be vaccinated, but they don't have a place that's safe to go to. And I spoke to this morning on another things to the forefront. Our call yesterday, Janet Smiley was there and she brought up some of the issues of not having access
that have come in. So I will roll up to professionals to answer the questions that we have in the inbox. So maybe I'll just put one out there. Both of you have touched on some of the questions either through this presentation or others. But here's some of the things that people are saying. How should I decide on getting a pandemic vaccine? As an individual, what criteria would you say is recommended that somebody kind of go through whether or not they should be getting one?
So I'll start with my bias. I think everybody should get one. I think it's necessary, but if you have anxiety about that, you need to find a reputable source. And we definitely put our hands up to be that reputable source. If you need to email me and ask questions, we're at those tables where we can ask, and I feel privileged to have that ability. So you need to make a decision on which vaccine too, which is important, and make a decision that you're comfortable with for sure. And I shared about the two that are in track one that obviously I hear a lot of people have fears about that. So if because it's a new vaccine and not as tested, that makes you a little anxious, don't worry, just keep yourself, safe. And then the next vaccine comes out and it's a traditional vaccine in more of traditional forms. But I think you talk to your healthcare provider too, because I think people are confused about some of the comorbidities as well and want to know really what their risk is. And that's something that you have to have a discussion with your healthcare providers too. I think if you're over 70, it's a pretty easy decision that you should go in and be there for track one.
Thank you, Kim. We also have, and it's been alluded to again, so in terms of pregnant women, not a lot of data or any data. Is that accurate? And then I think a follow-up to that would be, can you tell us whether breastfeeding moms should or will be able to take the vaccine? In for either one of you. And I saw Kim, you hit unmute, so.
I'm like the buzzer queen, I get it. I should have mentioned in the presentation, there are limitations to the study. But one thing that I forgot to mention is this vaccine for track 1 is not approved for under 18. So that is an important part. So if you're a child or under 18, you would not be considered a candidate for this vaccine. But Evan, I'm not sure 100% on the pregnant and breastfeeding. I'm not sure if those studies have been out, and I've just not paid attention.
Yeah, we don't have any data on its safety or efficacy for pregnant women, and so we will be asking them to step back and wait. We will be getting some information because some young women who are of childbearing age may get the vaccine and then become pregnant. It's different than being pregnant and then getting the vaccine. So they may give us some data going forward about its safety. So yeah, I don't think. So anyway, that's the recommendation. Given that there also might be situations where someone may be pregnant and have extremely high risk, and if they got infected with COVID, and so there may be some instances where it's where we might talk about a pregnant woman becoming or becoming vaccinated, but yeah, largely we're going to ask pregnant women to step back and wait.
Thanks to both of you for responding to that. Here's another question that came from the inbox, and we keep telling everybody, make sure you get your flu shot this year. What does that have? What effect will the fall flu season have during this pandemic? And can you tell us why it's so important to get our flu vaccine as well?
Well, we already have a burdened healthcare system, and we don't want to be part of that problem as well, right? So every year, and we keep hearing this funny little antidote that this is just like having the flu. And if you've actually had the flu, that's no walk in the park either, right? The flu does take people's lives. It does interrupt the quality of people's lives. So yeah, go get your flu. If you're over 65, go get the high dose flu if it's still available in your area. That's really important. Look up what the symptoms of the flu are. We've really avoided a bad flu season because of some of the good practices of washing our hands, social distance, and masking. But that doesn't mean we don't get the flu shot too. And it's part of our job to again, make sure we don't burden an already overwhelmed healthcare system that's at its pressure points.
We're also nervous about co-infection. What happens if you get COVID and the flu at the same time if you're unvaccinated for the flu? So it's just, I think, simpler if you're able to tolerate the flu vaccine to just go and get it now and protect yourself, and most importantly, protect others who are at risk of bad outcomes from flu. When I get a flu shot, it's because I'm around babies, I'm around the elderly, the knowledge keepers, and I'm mostly concerned about them than myself.
Thank you for that. Here's a question that came up a couple of town halls ago, but never made an opportunity to get on air, but we have the right people to answer this now. When we get into the discussions around antibodies, there is a question, and I think you'll be able to answer this. Does having COVID-19 antibodies mean you're immune?
According to Donald Trump,
No fake news here.
Evan, I'll let you answer that one. Take the tough ones.
Sure. Yeah, there's no evidence that your antibody response is sufficient for long-term coverage. In fact, it may only be helpful to you, and your antibodies may not make you fully immune, but maybe partially in a short period, as short as 3 months. So yeah, so I think you've probably heard of a leader just who was convinced that because he had it once, he couldn't possibly get it again, and that was not based on evidence at all. That was conjecture.
Sorry about some interference that we just had there. I'm going to continue a little bit on this track here, if you don't mind. There's 2 questions. Do multiple vaccines increase the risk or side effect or negative reactions? And then the other question would be, are reinfections more or less severe than the first?
I think you mean, does having a series of vaccinations, like a series of seasonal flu vaccines year after year, or childhood vaccines close together, like one at 8 months, 1 at 2 years, somehow incapacitate you or diminish you? Is that the question?
The question quoted is, do multiple vaccines increase the risk of side effect or negative reactions?
That's a good question. I would need to dig deeper on that one, but my sense is that if you've had a negative reaction to a vaccine, that you're more likely to have another negative reaction to a vaccine, and there are like severe and mild reactions. Most of us, if we're going to have a reaction at all, are going to have a mild reaction. So I would need to check, but I think, being just from personal experience, being an old guy, having had many vaccinations, I haven't seen a cumulative effect where every time I get a new vaccine, I feel worse than the last one. So I've not heard of that, but I should check the literature. And the second question is about, I know the answer is there's no evidence about the second reinfection with COVID being worse than the first one. There have been so few recorded incidents of double or consecutive infections with COVID that I don't think we can say.
Thank you, Dr. Adams. I really appreciate you taking a crack at that. I think the other area we want to go into now is just in terms of any kind of fraudulent telephone calls that may appear from the government of Canada. Right now, there's a telephone scam going on that will show up as the COVID-19 information service. So let's just be diligent about reminding everyone in our bubbles that please do not give out personal information if you did not initiate a call, and that there is not, and I'm looking at Kim and Evan to confirm that there is not a COVID-19 information service calling individuals asking for personal information.
No, not that we know of. And we would come back to you. Like I would say, we haven't nailed down how we're going to do the monitoring after, and some of that might be done through phone calls. So, but you should be informed when you get your vaccination that you have provided permission. And that's where we're going to try and collect some of the more fulsome data. But if you haven't reached out for care and you're getting a call, that could be assumed, in my mind, to be fraudulent.
Perfect. Thank you for answering that. Um, and this is just a general rule of thumb. I know we have a lot of folks who do watch from different demographics, and that's just a good reminder on anything. When somebody calls you and is asking for personal information, don't provide it. Really stop, don't do it. And if you really do feel like you're being part of a telephone call scam, you can report it by contacting the Canadian Anti-Fraud Center. And I'm sorry that this came up. I mean, all of this amazing hard work in a situation where we're at our most vulnerable and we have folks who are scamming our populations, all populations, it's shameful. And that's the second time I've used that word on this town hall series, and the one where businesses were sending large amounts to PPE to our nations without them asking for it and then billing them for it. So that's the second time I'm saying shameful on folks who are taking advantage during a pandemic. Um, I guess the other piece is right now, children are in school. We don't have studies, if I heard correct, about children 18 and under. They weren't part of the testing group. And I guess there's some concern right now from one of the viewers or listeners on air that children are vulnerable at school. And will there be a campaign at some point for vaccination for children in school like there is other vaccination campaigns?
Yeah, certainly. I think the overall plan is that everybody can be vaccinated. They've done the highest risk. And from the data that we've seen so far, the term super spreader was used at the beginning of the pandemic, and kids did not tend to fall into that. We've seen them go back to school with minimal problems with spreading, and any of the contact tracing that we've seen has been that it's been brought from somewhere else and not really doing much of the spreading in the school. So Evan, you can correct me if I'm completely off base, but my background from that is my daughter is a teacher in a Manitoba school. So, so far that has been, very much content, safe or not. And they're doing the right measures within the school and having cohorts. And as long as that continues outside of the school, we think this is still so far safe. And so the vaccination should follow. They're still working on it, but they really needed to prioritize the higher risk. And it was early on in the pandemic when it was determined that it was the older age.
Yeah, I think some of the early studies when we were talking about the children returning to school, where we were watching the Southern Hemisphere where children had already returned, and some of the early findings as they watched over those children and whether they became infected or not, or what circumstances, was that they were doing pretty well, that the measures were quite protective. And we're learning more around the use of masks, that they're fairly safe, and that some of the what we call adaptations or physical adaptations, or the staggering of student classes, sometimes they're virtual, sometimes they're face-to-face, usually they're in cohorts or a smaller group in a large classroom, were quite helpful. And whenever there were school cases, they were dealt with very, very quickly. And I would say that the tolerance for infection in school is low. So we all understood, all of us public health officials understood that children and infections in schools were not to be trifled with. So I think we have a low threshold for reaction. Yeah, you're not hearing about huge outbreaks in schools kind of around you. Most of us, we're hearing about it in other ways. In the country, we're not hearing anything about First Nations schools being places where people catch COVID. Much more likely in schools or when you travel out of community, and in family gatherings, particularly things like funerals, where where people can feel emotional, and maybe it's about a hierarchy of needs. When you're so, incredibly sad, maybe getting a hug feels more important than, trying to be safe about a disease that you haven't seen quite yet. I don't know. Anyway, people still need to be safe, and I keep saying, and you've heard me say it earlier on, now is still not a time to visit. So let's avoid that, and especially with Christmas and New Year's coming up. I hope you're making alternate plans.
On that note, Dr. Adams, what are you going to do for Christmas? You're in a one household. What does Christmas look like for you and your family?
That's so funny. I was helping my mother yesterday. My mother's almost 80. She got home, and I was near her. My office is beside her house, and I was helping her in with her shopping, and I saw Christmas gifts, and I'm concerned about her shopping, but she knows how to be safe when she's shopping, and she knows that we're all going to spend Christmas apart. I'm calling it Christmas in July. We can have Christmas every day at the end of 2021, and I can't wait. And I can't wait for the vaccine and some return of things like it being easier at work, or hugging my kids who are not in my household, my adult children, and even things like going on a vacation to someplace sunny. I just want to pick those things up again. I'm very motivated to to get vaccinated, and I'm hearing from those of us who are planning for the vaccination rollout. Lots of us are pretty excited. It's like, oh, can you imagine the change away from how we currently live?
I so appreciate that you mentioned let's have Christmas in July when it's safe to do so. And just a reminder, folks, it's one day. And I get terrified when I watch the news and I hear of all the US travelers right now and what that means for the US. I mean, that's not what nice Canada is going to do, right? We're going to be diligent, abide by the public health, and make sure you celebrate Christmas, because I know people are planning. Make sure you celebrate it in your one household with your folks that live at that address, right? What you need to do is
It preaching it all until it came down to my home is Prince Edward Island. Just little babies being born there, and had all the talk to go. My grandfather died during this time in Prince Edward Island, and I had to make that difficult choice. And it was emotionally very difficult. And now with my daughter, her first year away teaching, and she has nobody there, and she'll be alone. But she talked me through it. I was trying to find loopholes. So I'm as guilty as everybody else. I was really trying to find these little loopholes. And she said, Mom, at the end of the day, how do you feel if I brought this to Nan, to my mom, or I bring something back to those kids I teach? She goes, it's not worth it. And she goes, I promise I'll see you if we just hunker down. So I don't want to pretend to be better than anybody. I don't like this shaming that's had my weak times where I was just want to get there and get her and stuff. And so we continue to have these discussions. Grown children are some of your hardest because they pull at your heartstrings. Well, I guess you just don't want to come see me. And it's not that, so I'm not a hugger, I'm a nerd, but now I am craving that interaction for sure. So I think we should talk about it more openly of how hard it is and some of the thinking we're doing, because I've heard people rationalize some of their choices. And I think people should have more discussions about it to say, well, I think that's not a good choice because of this, this, and this. Not judging us, but that's, my daughter did it for me. And I've come to a good decision where it's just going to be our household here. So it's going to be different.
Well, and that is what this is all about, opening the dialogues across Turtle Island so that we can make informed decisions with credible and reliable information. And that's why we'll continue to host the virtual town halls, why we seek out such competent and nerdy and friendly and fabulous guests like we do every week. Evan, I know you're not with us next week. We will miss you. And Kim, we'll be sure to have you back in the new year to give us an update on all of the information that will be available for you to share around the vaccinations and how that's all coming together. Now it's that time where we say, give gratitude and thanks. And that's really what this is all about, is to remind folks you're not alone. You may be one person, but you have a network and a family and information via the radio stations, the internet. And I hope my crazy nerdy, as Kim says, smiles and smile as would like to Facebook. We have Seed News, the 7 Nation News, Element in you guys.